The topic of our second stage of the morning is understanding shocks and catalysing system reform. So very much building on the earlier presentations. Personally, I'm very interested in this topic, and I've been thinking up questions for George and Liz since yesterday. So we'll see how that goes. Our first presentation is from George Wharton, who's a senior lecturer at the London School of Economics, and obviously has been a key person in building, we were chatting earlier, in building the partnership for health system resilience and sustainability, and we had an interesting chat around how the development of the concept or the construct of resilience is now being, if you like, balanced with that question of sustainability, which I think also leads into the topic that both Steve and Padraig raised earlier about legacy and learning and that element. So George is going to present a case study, if I understand correctly, a case study of case studies. And I think, very interesting to hear, I suppose, the experience in practice, given that case-based approach. And then we're also going to hear from Dr. Liz Forsacci from the Centre for Health Policy and Management. And Liz is a research fellow on the Restore project. And Liz is going to present on using crises as catalysts for change, legacies and resilience amid shocks to the healthcare system. So we look forward to both presentations. We will have some time for Q&A after the presentations. And so please start scribbling and noting your questions so we can have a lively session after the presentations. So without further ado, I'm going to hand over to George. Thank you, George.
Thank you very much for the invitation to come and speak and be part of this event. It's a real pleasure to be here, and it's been a pleasure to work with Steve and the whole team at Trinity over the last year or so in producing the Restore report. So yes, I'm George Wharton. I'm a senior lecturer in the Department of Health Policy at LSE, and over the last 3 years I've been involved in helping to set up and run the Partnership for Health System Sustainability and Resilience. LSE is the anchor academic partner in PHSSR, as we refer to it. And I'm going to tell you a bit about the project, sort of where it came from, how it works, and what we've done, and also what we hope to do, and obviously very happy to take questions, particularly in terms of how we hope to take research into evidence and practice. So the Partnership for Health System Sustainability and Resilience was established in 2020, and it was really catalysed by the COVID-19 pandemic, which clearly was a crisis that kind of constituted a call to action, and we thought created a window of opportunity for timely, high-quality policy research looking at health systems to identify how they could be made stronger, both in terms of sustainability and resilience. But this research should include, actionable, policy-relevant findings and recommendations, and that we were well placed through a collaboration between LSE and initially AstraZeneca and the World Economic Forum to run a project like this in collaboration with research partners across a number of countries. So, please excuse me, my phone just buzzed. Put it away. So we launched in 2020, and over the last 3 years, the partnership's been established. We now have a number of other partners involved, including Philips and KPMG, the World Health Organization Foundation, and a new institution called the Centre for Asia Pacific Resilience and Innovation. And I should mention that LSE is funded for its role in this partnership, and we, in turn, fund our research partners in countries. The honourable exception to that being the team at Trinity, who undertook this work without any funding from PHSSR or LSE. Just a little bit about the organisation and the individuals involved, because we have a steering committee who are effectively the leadership of PHSSR, and senior representation from each of those organisations has essentially guided the development of this partnership. And the kind of complementary strengths of the different institutions and organizations involved in this partnership, I think, bring both kind of academic capability and credibility, plus great international reach. Because, for example, AstraZeneca, Philips, and KPMG have a presence in every single country where we work, and they bring a lot of in-kind support and appetite and interest in supporting the process of the research while respecting its independence and subsequently helping us getting it into the hands of policymakers. And of course, with the World Health Organization Foundation and the World Economic Forum, we also have tremendous ability to convene at events like Davos and the World Health Assembly and so on. So what do we actually do? Well, we support health system assessments led by teams of local researchers with input from health authorities and health system stakeholders. And these assessments inform recommendations for health system strengthening. What do we actually mean by resilience and sustainability? Now, this is a key question, because at the very outset, we began thinking solely about resilience. And to be honest, before I started working on this project, my thinking about resilience was basically crisis preparedness and response. How do we deal with and respond to crises? When you really unpack the concepts, you'll find that they're much more complex. They're used in varying ways in different contexts, and their relationship is far from clear. Now, resilience, I think, has been spoken about a lot today already, so I won't go into that in too much detail, but suffice to say that if I was to boil it down, I would say it's about how health systems deal with adversity. Now, sustainability is used in different ways as well. It's often used to refer only to environmental sustainability, or people think about it in financial terms. The way that we think about it in PHSSR is much more holistically. And the key word there is about it's continuity. So how does a health system continually deliver on its key functions and objectives, adapting to changing concepts in doing so? So if resilience is about how health systems deal with adversity, sustainability is about how a health system is able to deliver on its functions on objectives in the longer term. And critically, if a health system lacks sustainability, you could argue it creates adversity. It creates the conditions in which its resilience is called into question. The relationship between the two concepts is quite complex, and there are lots of interesting things you can say about it, but we believe they're mutually reinforcing, and also that neither is sufficient. Both are necessary, neither are sufficient. And we would advocate for a kind of a dual focus, not just focusing on what needs to be done to deal with adversity, but also how can we continually sustain improvements towards population health. So that's what we resolved to do. And we've essentially developed a qualitative assessment framework, right? So our framework, it's a piece of guidance really for the research teams that they use to produce their country assessments. And it includes questions and lines of inquiry across these 7 domains. Now, in each domain, there are questions and lines of inquiry that relate specifically to resilience. There are those that deal with a much longer term sort of foundational perspective, and there are those that deal with both. But the idea is to put a tool in the hands of researchers that enables them to work quite rapidly, that is very easy to use, and can produce broadly comparable reports across countries by teams working independently, with LSE providing kind of hands-on support in doing so. And we've learned a lot in the process of the last 3 years and are continually refining the framework. Notably, we added those 2 domains, environmental impact and population health, in the second wave of reports. They weren't included in the first set, but we think that they're essential. So which countries have we covered so far? Well, 20 countries highlighted on this map. And we hope to continually expand the partnership. So in the next wave of research, we'll be conducting health system assessments in a group of 5 sub-Saharan African countries, and we are just initiating work in Asia Pacific with another 5 countries there. But overall, 20 countries almost complete at this stage. So a large body of work. Each of these reports is about 100 pages long, contains tens of recommendations, so it's a huge amount of material that's been generated. And seeing how you can best synthesize that material and make use of it when it's, quite a lot of it is very kind of rich, but very country specific. How do you draw lessons from one country that you might be able to apply to another is a key question in how we take the work forward. So we're very lucky to work with a fantastic range of research partners across those countries, many of whom are listed here. And I think that this is one of the key achievements of the partnership, because I think what we have here is a community of thought and practice in thinking about sustainability and resilience of health systems. And we very much intend to keep this community alive with additional research and activities, conferences, events such as this, and in international fora, bringing them together to present our work to international audiences. We are rolling out new reports kind of on a weekly basis. Obviously today we've got the Ireland report being published. I think tomorrow or the day after we've got the Netherlands report. Soon after, the report from Brazil will be published, and then a few more between now and April. But all of the reports are available at phssr.org, and an overarching report which synthesizes the findings across countries will also be published imminently in the next sort of 2 months. So the country reports contain country-specific findings and recommendations, but there are common themes and trends that emerge across countries. I'm just going to speak about a few of these and highlight some of the lessons learned with some specific example recommendations that we've seen. So firstly, governance. One of the really pronounced themes that we've seen in the reports, in the sections on governance, is just the complexity of governance of health systems and the necessity of having effective multi-level and cross-sectoral coordination mechanisms. Health systems are, on the whole, rather fragmented in their governance. This applies to both systems that are more centralized and systems that are more federated or decentralized. The challenges appear to be relatively common. And we often hear of coordination or integration as a kind of watchword for the next stage of development of health systems. But how do you actually realize that without integrated funding mechanisms, without integrated mechanisms for making decisions and sharing accountability for health system goals? Now, if that is a broad policy direction, we see specific recommendations in each of the reports for how that might actually be achieved. So an example from Canada: strengthen mechanisms for collaborative action, improve transparency and clarity of roles, and as well, implement a pan-Canadian health data strategy. Now, clearly, that recommendation, it's specific enough to offer some definition in terms of what the objective should be. The question is, how can PHSSR contribute to developing an actual actionable or implementable policy on that basis? And again, that is the next step for our work. Financing. Perhaps unsurprisingly, and I think it's relatively well known, that incentives across health systems remain quite poorly aligned to health system goals. In many of the systems that we've studied, we found that payment mechanisms are still largely fee-for-service, okay? Which may be very good for incentivizing productivity, but isn't necessarily going to contribute towards value. So we are seeing in the reports recommendations around moving to different, more innovative financing mechanisms, including global budgets, actually. So it's not just about payment for performance and blended financing mechanisms. In some cases, we're seeing recommendations about taking a much more, an approach that might seem rather backward-looking, but could indeed help to promote accountability for a population's outcomes. In terms of workforce, well, as we've heard already, the resilience of the workforce has been tested to the point of unsustainability. Something I wanted to emphasize here is that if you have a workforce that is unsustainable in the sense that its numbers are reducing relative to population needs over time, then its resilience is going to be called into question at some point. And when a stress or a shock like COVID-19 comes, that can that is a shock in and of itself, but in an unsustainable system that doesn't have any capacity to rebound, doesn't have the ability to reassign resources or inbuilt flexibility. What we're seeing in some countries, and I think that this particularly applies in the English NHS, is that the trajectory since COVID-19 has accelerated in a negative way quite significantly. So the question is, what strategies can we put in place to address that? Now, we would advocate for action to improve working conditions, first and foremost, to improve the resilience of the workforce. And there are obviously multiple measures that can be put in place to do that, but things like reducing the administrative burden, enriching job profiles and career opportunities to improve staff morale, and indeed the effectiveness with which healthcare professionals are able to practice. So for medicines and technologies, a sample recommendation here is about strengthening international collaboration and cooperation. Rather bitterly, as someone who's based in the United Kingdom, at a time when our participation in Horizon and so on is being called into question, it does seem that international collaboration is going to be absolutely critical in how health systems are able to deal with crises in the future. Finally, rather not finally, almost finally, service delivery. One prominent theme that we're seeing in service delivery across the reports is the extent to which health systems remain very hospital-centric. This emerged particularly in a number of European countries. And the extent to which primary care in particular is underemphasized in national policy, underemphasized in funding allocations, underemphasized in training. And ultimately, this is going to have seriously deleterious consequences for the health system overall. So we have recommendations across all of our countries in strengthening the role of primary care. And here you can see an example recommendation from Belgium. Population health. Now, this is a really important one, and particularly because while we're focusing on health systems, we continually advocate for more investment in health systems, for more training of healthcare professionals and so on. It's never going to be sufficient if population needs accelerate or increase out of hand while resources remain relatively stable or are ultimately unable to keep track with, to keep pace with increases in needs. Health systems pick up the pieces from other areas of social policy, public policy, and we can't expect them to be able to maintain good outcomes if they're dealing with ever-increasing needs. We shouldn't always seek a clinical, well, we need to find clinical cures for things that have social causes, but ultimately we need to address the social causes too, right? So health in all policies is a really, really strong theme across the reports. And again, in some of the countries, you see that there are well-established frameworks in place for things like health in all policies. In Saudi Arabia, for example, they have a committee on health in all policies that is intended to bring together ministers and senior officials and ensure that it's fully taken account of. But in some European countries, you see that it's very, very little emphasized. Okay, so there are some interesting comparisons to be made between countries and some surprising things that you see in terms of financing, for example, where you have very, very rudimentary financing mechanisms in countries that have relatively sophisticated health systems. And finally, environmental sustainability. Now, clearly, health systems have a significant environmental impact, and health systems are also seriously impacted by the environment. Okay, but what we're not seeing across most countries is that being taken seriously, particularly in terms of measuring the health system's impact on the environment. It's not routinely captured in many countries. It's not seriously measured. And there are very few countries that have well-defined strategies in place for dealing with the implications of climate change, for example. So Saudi Arabia is a good example because in this case, it is something they appear to have taken very seriously. And The Saudi Arabia report for PHSR is on the way. It's probably another 8 weeks away from being finalized, but the environmental sustainability domain of that report is incredibly rich and detailed. And I think, again, there's things that some other countries can learn from in terms of how seriously the environmental sustainability of the health system is being taken there. So there's a sample of our findings. In terms of what we do with the reports, well, this is the start, right? For Ireland, it's not the start, actually, because experts and stakeholders being consulted throughout the process are aware of and have contributed towards the findings. But we launched the reports and then subsequently seek to promulgate the findings. So we've had a really great set of launch events across a number of countries. We also have access to platforms such as the World Economic Forum, and also run our own annual conference or summit. What we want to do next is, firstly, another 6 country reports that are already on the way. We're working on an EU-level report, which is going to look at actions that particularly the European institutions can take to strengthen health systems across the continent. We want to sustain engagement with policymakers on the findings and the recommendations that are within the reports, and I'm going to say one more thing about that in a moment, and also launch research in 10 more countries and expand our kind of global reach. And I should say as well, we also look to expand the partnership and bring other public and private sector partners on board. So how do we go from research to action? Well, we have a concept for this, and it's being worked through. But as I mentioned, there are tens of recommendations in each of these reports. Now, research does not itself create policy change. It can't create policy change directly. And when you've got such broad reports that are so rich with findings and recommendations, you can't expect all of them to be taken up either. Neither can we as a partnership invest resources and energy in promoting every single recommendation. So we have to prioritize, right? We have to prioritize and identify those where not only is there a problem and a policy option that could solve it, but also the political context creates an opportunity that we can actually feed into. So can we bring stakeholders together to discuss and debate recommendations that might be high-level policy directions and help bring them to a more developed stage of definition? And yeah, hopefully knock some heads together in some cases. In any case, that is it from me. Thank you very much for listening, and look forward to your questions.
So first of all, as Sarah said, I'm Liz Farsacci, and first of all, I just want to thank you all for being here, and thank you to my team, Steve and Pork and Ariana and Catherine. They've done all the hard work. I've joined the team fairly recently, so they've done all the hard work, and now I get to bask in the glory of health, resilience, and sustainability. So thank you to my team, and thank you for being here. I suppose I'm conscious that I'm the last speaker, and I suppose one of the things that I want to do is kind of tie everything together. I'm going to be presenting, and then of course we have the panel discussion to look forward to. So stay for that, ask all the questions. I'm going to be presenting some qualitative data, so I'm kind of, the way I look is I'm kind of putting some flesh and some voices, flesh on some of the findings that have been presented already today. So really, with that in mind, I have 2 aims really of this. I'm going to be presenting qualitative data from 2 shocks to the system, from the austerity years and then from COVID-19. And really, I'm going to present those, and then really, instead of drawing conclusions, I suppose I'm going to be asking questions. So I'm going to be reflecting a bit on the lessons we've learned based on that qualitative data, and really how we can move forward together. So I'm really interested in hearing everything that you have to say about that. In terms of the presentation, I'll just very briefly do a recap of the shock model. Thank you to Steve and George, who've already done that for me, so that's great. I'll just do a quick recap on the shock model as well as resilience and sustainability, and then I'll spend the majority of the time on the qualitative findings. These are based on 7 interviews that we've done with key informants, and then as well, then I'll conclude with the reflections and questions. So I suppose this, again, is the shock model. You've seen it before, that Steve and colleagues have developed. You've seen it before, and really I want to focus on, I'm going to be asking questions about stage 1 and stage 4, preparedness, and then recovery and learning. And I'm going to be talking about, I'm going to be talking about whether we need to perhaps reweight or rethink this model, or reweight the different stages of it. So really, be thinking about that as you listen to the qualitative, to the quotes that I'm presenting today. And George touched on this, and a couple of other presenters touched on this. For me personally, I would say that resilience is not just the ability to deal with an acute shock, but to me, the ability to deal with ongoing crises, or underlying crises that we have throughout every day, and that, to me, that ties into this idea of everyday resilience. And thank you, George, again for talking about sustainability. I would again argue that sustainability is really the point of resilience. What's the whole point of being resilient? And we're thinking about how all these different aspects, workforce, infrastructure, finances, how it can be resilient if we don't have sustainability, if ultimately we can't provide care and people have access to care. So to me, I suppose I bring that up just because to me, that's the point of everything, is providing care to people. So in terms of the qualitative findings, it's really contrasting these two shocks. The findings we have are really contrasting responses to these different crises. First, of course, we had the economic shock and the financial crisis and the austerity years. And really, this was characterized by financial constraint. These years were really characterized by financial constraint, a squeezing of finances and, an inability to access finances. And this, of course, had an impact on capacity and infrastructure. Secondly, we had the Troika and a shift in governance. So this, there was a shift in governance and decision-making as it became more centralized. But then also some of our participants or some of our informants said that this was useful in some ways. Some politicians, some national politicians, some Irish politicians used this then to kind of blame Brussels for agendas that they kind of wanted to push through that were unpalatable to the public. And then my colleagues, of course, there was effect on workforce shortages and low morale. That was also a massive part of this shock to the system. In contrast, then, we had the COVID-19 pandemic, which was, of course, a health shock. But then, of course, as my colleagues have mentioned, legacies remained from austerity. So as Steve said, we weren't necessarily fully prepared for the next shock. But really what characterized this, as opposed to the financial crisis, was a massive financial injection. Suddenly there was funds, and I'll show you the quotes from that time period because they're really interesting, can help us think about, just appreciate how much money was available and was going in to the system at the time. And this really created a difference in culture and a difference in decision making. This really, I would suggest, maybe you disagree with me, but this, in some ways, health leaders were able to purchase more agile decision making. You can disagree with me on that or not, but certainly this financial injection and an easing of some fiscal rules across Europe enabled leaders to make flexible decision making, create a new culture. Then also, as my colleagues have mentioned, it also created COVID created new pathways of care and increased access in some aspects. I'm not going to talk about that today, but that's obviously a very important issue and opportunity that arose from COVID-19. So in terms of austerity and the financial constraint, we're going to spend a few minutes talking about the qualitative data from the austerity period. And really, I think this participant says it in a nutshell. They say that period, the austerity period, was a period of massive extraction of resources from healthcare. I mean, that really says it in a nutshell. And this participant says, I think the financial crisis did delay a series of reforms that we needed. The investments that were needed were delayed during the financial crisis in primary care, integrated care, and infrastructure, and better conditions for professionals. So that participant's really speaking to both the effect that the financial constraints had across the health system. Now, this is also interesting because, of course, This is the shift in governments, and then this has to do with kind of a shift in governments and then decision-making that was taking place during Brussels. This participant said, I think the politicians were grateful for the Troika because the Troika allowed them to do things that would not be palatable on a national level. And blaming Brussels was a very useful thing to do. So that really speaks to this. And then as well, the second participant says, the members of the Troika were interested in kind of looking at different analyses, but then the meetings were largely being used to drive the political agenda and then blame it on the Troika. And of course, this centralized decision-making had an effect on services. And the final participant speaks to this. They say, I think the experience was too over-centralized. They're talking about the decision-making. And that puts too much of a burden on the center that was too far removed from the service. And then there's a danger that you create with this, there's a danger you create an insensitivity to the patient and service user experience. So this talks about, again, the effects that centralized decision-making that was far removed from service delivery had on service delivery and patient access. And finally, then, I won't focus too much on this because my colleagues have focused on this already, workforce. Of course, the austerity budgets had a massive effect on the workforce, and many of you were working, in the health service at that time and very much experienced this as a lived reality. This participant says an awful lot of leaders left the system. So because, of course, of the austerity measures, there were a number of budget cuts and a number of people left the system. So I think I'll highlight this middle one first. I think 2010 was a time when we lost 2,000 people within a 6-week period. And that, in its own way, was both a service and an emotional shock to the system. So that happened. There's lots of staff leaving very quickly. And the other participant says, a lot of those people were leaders as well. So not only did you have this massive exodus of staff because of cuts, but then also you had a lot of the people who left were leaders, and this had knock-on effect in terms of knowledge and experience on the ground. And this, I suppose this is a nice, this final quote is a nice one because it talks about how we were going into COVID then. Our health workforce is not holding and mental health issues are rampant. I think that is an inheritance of the financial crisis with the additional huge pressures of COVID. So that speaks about, and my colleagues have done this realist review and this other case study as well that really speak to kind of the workforce was exhausted after, throughout austerity and then had COVID. And then, then that has kind of brought up that burnout again. And I suppose I'd put a question to the audience. Really, I'd love to hear your thoughts later on about what can we do to help the workforce be more resilient and to really provide the support that our workforce needs to provide services. Because we have the research now, we all know this stuff. So I'd be really interested to hear your thoughts on what we can do to support the workforce. Now, switching to COVID, I suppose I've just included this one quote because I think it really captures it in a nutshell. The negative side is that the health system went into COVID very much diminished and under huge pressure, morale was low and finances were tight. And I suppose that kind of really says it all, doesn't it? Going into we had the austerity years and that economic shock and the lack of resources that were consistently, not put into our health service, not available to our health service for a number of years. And then we had, so that was, that had an effect throughout the different layers of the health system. And then we had COVID. For this, I really want to talk about, this really highlights, these quotes really highlight the difference then between the different reaction to the health crisis that was COVID-19 and really the differences in finances. COVID, as I said, was characterized by an injection of finances. As this participant at the top says, they say the pandemic period was a period of massive and rapid injection of resources in the healthcare field. So instead of an extraction, it was a massive and rapid injection of resources. And I think the second one, I'd be really interested to hear what those of you who worked in the health service think about this. This participant says the budget totally changed. Thinking around money and thinking around budgets totally changed. They say you're told essentially to go, since COVID, the budget has been completely a work of fiction because the COVID part of the budget is not included in the main line. So you're told essentially to spend what you need to spend, then come back to us and then negotiate to get it back. And so that's, of course, very different thinking compared to the austerity years, isn't it? And then finally, this created a different culture and different culture around decision making. And there was, I think my colleagues have mentioned that there was this agile decision making. And of course, we had this rapidly evolving situation that had to be responded to very, very quickly. And this created different culture around decision making. And this participant really speaks to the idea that decisions had to be made rapidly. And that doesn't necessarily mean that they were the right decisions, but they were the right decisions at the right time. And you didn't have time, you didn't have the luxury of spending too long on making decisions because you had to respond to the pandemic quickly. So this participant says, did they make decisions at speed? That's health leaders and politicians. Did they make decisions at speed and apply resources to the priorities? Yes. But if you take too long, but there's no criteria, however, to say that you have to get everything right. Because if you take long enough, there's going to be certain decisions that you're making right, then you've taken too long. So I suppose this is so kind of with those ideas in mind, we had the austerity years, we had COVID. Now we're looking at, Steve and colleagues have talked about a permacrisis. I suppose I want to ask, what sort of future are we looking at? Is it a permacrisis? One of our participants was referring to the cost of living crisis as a slow shock. And they say, what I mean is, I suppose this is a slower shock, the cost of living crisis, as opposed to COVID, which was a very dramatic thing that happened. And the economic crisis, the financial crisis, was also very dramatic. And I think the cost of living crisis has just sort of happened with more stealthy, sort of slow onset. So I think it's really important for us as we go into the future. Are we looking at a future of permacrisis? Are we looking at slow shocks, acute shocks and then slow shocks? But I suppose really, are we, if we are facing a period of permacrisis, are we facing a future when there's no stage 4, when there's no recovery and learning? And finally, I'd like to conclude. I'm conscious that I'm the last speaker, and while we have the panel discussion, I know that you've been listening here for a while, so I will just wrap up with a few reflections and questions. I suppose one of the themes that's been throughout this morning is that it takes a shock to highlight weaknesses and provide opportunities for change. So I think this is a really, as Ewout said, we're already, it's really important that we don't miss the boat in terms of learning from the COVID-19, because we're faced right into, the cost of living crisis. So I suppose if we face, let's say we're facing a future of permacrises, it seems to be that we are, although maybe we're just making that up so we can stay in research, I don't know. But if we are facing a future of permacrises, how do we ensure and protect the health system resilience and sustainability throughout the way? Do we need to reweight the stages of the shock cycle? Or perhaps more importantly, do we need to integrate stage 4, integrate recovery and learning, integrate preparedness throughout the whole cycle? Maybe we don't no longer have these lovely 4 distinct phases. Maybe we need to be doing it all the time, which of course brings its own challenges, doesn't it? So I suppose really, as we face a uncertain future of permacrises or slow shocks and acute shocks, I think it's just really important to take the lessons that we've learned and the thoughts and the voices of experience that we've heard in our qualitative data and think about how we can make how that affects our work and how we can make the health system more sustainable and resilient. Thank you.
Loads of thoughts, but let's just open up to the floor straight away and see if there are any questions in the room. Greg, was that a hand up or? Yeah. Excellent. Move this.
Yeah.
Oh, sorry.
Thanks for the presentation, it's very interesting. George, I just had a question for you. You spoke about environmental sustainability. I think you suggested it wasn't being taken seriously, which I think is probably fair enough. Have you any ideas of why that might be the case? I'm guessing, certainly in our department anyway, it's scarce resources, probably other priorities, just bandwidth. But any other ideas? Thanks.
Well, you've taken the words right out of my mouth, I think. Yeah, I mean, health systems are continually wrestling with multiple kind of emerging and established crises and issues. I think the challenge with something like the environmental emergency is that it's been a very kind of slow build, and it has yet to, within health systems, get to the very top of the list of priorities at any given point. You know, it's there continually, and it's growing more urgent, but at some point, something will happen that makes us all stop and say, okay, well, this is the next priority. This is the next number one priority. So I'd say it's a question of wrestling with multiple priorities, and there having been so much else going wrong over the last 5 to 10 years. But there are encouraging signs in the sense that there are so many emerging policies and strategies, particularly, you know, we're certainly seeing them in Europe. The question is, once those strategies and policies have been defined, do they actually result in serious change on the ground? And you know, that's another question entirely.
Thank you. Liz, do you want to come in on that one?
I suppose I'm wondering, would it help to just briefly continue? I suppose I'm wondering if it helps, do we think of the environment as something else, another list on the to-do list of things to do, or is there a way that we can think about integrating it into, so it's not just we don't have the bandwidth, it's another thing we have to do and we don't have the bandwidth for it. I'm wondering, I don't know the answer, I'm wondering if there's a way we can integrate it into all facets of the health system and of our life and stuff. Easier said than done, obviously. But,
absolutely. But you know, if you adopt a kind of a One Health, planetary health perspective and recognise the extent to which it is all interlinked, then yes, absolutely. Yeah. I mean, we would like to see a kind of a One Health perspective embodied in again, in the same way as health should be in all policies.
Yeah. Great, thank you. Colin.
Hi there, thanks for an interesting discussion. I think my question is probably going to be more appropriate for the panel. Sarah's, but I'm not going to be here, so I'll ask you. Actually, I have a comment and then a question. So Liz, you said something interesting. You wondered whether somebody from the front line might comment on whether or not the financial crisis might have created some agility, because, you know, the comments were universally terrible, you know, from people seeing people leaving the health system. So I'll just give you my own perspective on this, because I worked as a frontline clinician for 20 years in this system. So a hospital-based consultant looking after people with epilepsy. So in 2008, the discussion about neurological services was always based around getting more consultants. But when the financial crisis hit and Barry White took over the clinical programs, we made a pitch to say, listen, we think we can train nurses to do what consultants do. And we got 3 nurses for every consultant. And actually, but in 2010, we got agreement for 25 nurses, which we appointed over 5 years. Now we've got the best nurse, you know, a clinical nurse specialist to patient ratio in Europe for epilepsy. So that all happened because of the crisis. The conversation shifted, and, you know, a more resilient way of dealing with epilepsy cases came on board. But what was very interesting about that, by the way, the second thing we did was we created an electronic record, a completely integrated, albeit siloed, electronic record which crosses institutional and geographic boundaries. And now we have 50,000 years of patient data on this system, which is ours. It's not owned by a corporate body. So what was really interesting about that was when COVID hit, And nobody wanted to put money into chronic disease services. Remember, everything was about the ICU, everything was about, trace and track, all that sort of stuff. So people with chronic conditions were underserved by all the money going into the acute system. But of course, we now had a system where we could actually do teleconsults, point of care, we had an electronic record, we have a patient portal. We had nurses who thought this job was perfect for them. There was no resistance from them. And we've published on that and how valuable the patients felt that was. So it was an interesting connection between the two crisis periods, that one fed into the other and made us resilient for the second crisis. The second point is a more general question, which is the one maybe more suitable for the general panel, but I'd appreciate your view. So the word crisis obviously comes from this Greek word meaning a judgment. That's what the word comes from, right? Now, like, what is going on that everything is a crisis? Because if it really was a crisis, we would be using those to make judgments for change. And yes, I know about the the crab in the boiling water thing, about certain crises we are coming up on us and we don't see them coming. So there's an issue about the speed. But the reality is, we've got to get away from calling like our A&E crisis a crisis if we're not going to make a judgment to change things. Like, you know what I mean? Like, we have to use the word crisis. So I object to the term permacrisis, because to me, it's not we are not constantly pivoting all the time to address things which we call crises. And I'd appreciate the panel's view in general on that definitional question.
Mm-hmm. Thanks, Colin. Any comments from George or Liz on that one?
Okay.
Particularly on the permacrisis idea.
I suppose I'll respond first. Thank you for your experience. First of all, thank you for your experience and your comment on the front line. And I will say as well that I worked in the City West COVID testing center during the pandemic, and then was part of the rollout of local community testing centers throughout the different phases of our testing approach. So that was really interesting to kind of have that lived experience and then have it reflected in research. So as well, and then you have your lived experience, and many of us have that. So I think that's really important. I suppose secondly, in terms of the word permacrisis, I think I know what you mean in terms of saying maybe we shouldn't do permacrisis. I agree we shouldn't call it crisis if we're not going to do something about it. But I think it's also really important to continue talking about it until something is done. And I suppose, so that's one thing I would say. I think we shouldn't have to be calling things crises necessarily, but I think we need to sometimes in order for things to be done about them. Then from that leads to this idea that, well, let's do something about it. So that piece needs to happen, let's actually do something about it. And then secondly, for me, I really like this idea of acute crises and then everyday crises. And maybe we don't need to say everyday crises, but certainly everyday challenges. So I really think we have, or is it whether it's polycrises or permacrises, we have, there is this language that we use as researchers that, but I think it does, but whether or not we're just using that language or creating that language, to keep ourselves in business, we actually, it is true. It is speaking to these ongoing challenges that we have, and then speaking to these shocks then that do happen to the system. So I need to, so George, I can feel you.
Have you a quick comment on that? Definitely exercise, Liz.
Just to add briefly, because I agree with everything you said. I think there is a sense with crises that, well, hang on, they might pass, right? Crises, certainly the implication for me is that a crisis is time-bound, right? That's why the permacrisis phrase is slightly odd for me, because, and this is how I think about sustainability, right? Because the permacrisis is a result in a lack of underlying sustainability in our health system, our broader social systems, our economy, our approach to the environment, etc. It's a lack of underlying sustainability, and it is going to continually throw up new crises unless those underpinning issues are, maybe not sorted once and for all, but chipped away at, and that's the best that we can do. So that's the way I think about it. That's why I think that sustainability is a useful concept in tandem with resilience, because it explains to a certain extent where these crises come from. I hope that makes sense.
Okay, thank you. So just in the interest of time, but I'm going to use my position, abuse my position as chair to make 2 quick comments. I think the question about crisis is really interesting, Colin. To me, in a sense, crisis is just change. And therefore, I think it's trying to understand the nature of the change that we're actually dealing with. And as somebody, you quoted Greek philosophy, so I will too. Heraclitus said, we're never in the same river twice. So, I mean, the one thing that we know is constant is change. So that's just one comment. And the second one is just very quickly, I said I had been thinking about this overnight. And I was really struck by just the premise of the title for this session, which was Understanding Shocks and Catalysing System Reform. And I just wanted to kind of give ourselves a kind of a check and be the devil's advocate and say, is the idea of a crisis or, using crises for system reform is a little bit of a kind of an abstract luxury? Because actually I just want to remind us all that, COVID, the cost of living, or whatever the particular label we're putting on the change that we're going through has real world effects. We're saying that population health matters. People are on long waiting lists. People are, people died, et cetera, et cetera. So just want to just put that caveat in about, I think it is really important about our language and just how we're thinking about, as I say, not moving away from just abstract luxury into very much patient-centeredness, which I know is at all of our hearts. But listen, thanks for a fantastic session, and looking forward to the panel discussion.
Thank you.